Ceux qui viennent d'arriver, vous pouvez me donner vos noms, s'il vous plaît? Parfaitement. LM2. LM2. Anna, tes camarades parlent anglais. Je fais la première pour l'IM2 Pharmaco, Domas Léo. Arrivé. Fogère, Caro, Biontini.
Oui.
La battue, Marchisio, Théâtre, voilà. Pellegata, et Réolisa. Et Barré, et Carmina. Hélène, bonjour, vous nous entendez?
Oui, très bien, bonjour.
Les derniers arrivés, vous me donnez vos noms? Vélo, ok. Et bon, on va commencer quelques informations générales sur le M2. Je fais 2-3 phrases en français et ensuite je parlerai en anglais. Donc, vous l'avez compris là, sur cette UE thérapie antitumorale, vous allez être mélangé. I'm going to speak English in a few seconds. Vous allez être mélangé sur 3 promos, les innovations pharmaco, les M2 Care et les M2 cancéro. D'accord? Les M2 Care correspondent à une promo qui contient des étudiants étrangers, donc non francophones, et également des étudiants français qui sont en stage à l'étranger, d'où la visio. Donc tous les cours auront lieu dans cette salle avec une retransmission visio pour les étudiants qui sont en distanciel. Normalement, tous les cours sont l'après-midi pour permettre à ceux qui sont aux États-Unis, par exemple, de se connecter. Mon cours est un peu particulier, il n'y avait pas de place dans l'emploi du temps et en fait, j'ai une version en vidéo qui sera donnée à ces étudiants-là, mais on a quand même maintenu le présentiel pour tous les autres étudiants. OK? So I'm going to start speaking English for the class. Some of you have sent me some message with worries about English speaking, especially for your presentation. So you have understand that you will have to present some papers during the workshop in English. Of course, we will be very I mean, not exigent with your English. The teachers are not here to give you a mark based on your English, but you have to know that in the scientific, I know that you already know that, but in the scientific field, you will have to speak English very often. Maybe in the lab where you will do your internship, there will be some English students and you will have to speak English when you present your work. So I think it's a good exercise. And I know it's maybe for some of you a lot of work to do, but this is something that will be very useful for you. So you will have to make your presentation in English. If you have some problem to understand the English of the teacher, or if you have a question in English that you don't understand, of course, you will have the right to say, can I say it in French? Then the teacher will try to translate for other students and try to explain it in English, okay? So don't forget that the objective is that you understand the biological message of the class. So don't stay, if you don't understand, do not hesitate to ask questions, even though your English is very bad. And the teacher will try to translate it and rephrase it so that you understand. Okay? So I am going to ask you what's your name? Okay. Are there some students that I didn't call? What's your name, sorry? Jules. Jules. Okay. Before we start, do you have other questions regarding the organization of the antitumoral therapy class? So you have understand that you have 2 weeks of classes this week, and then in 2 weeks you have every day a workshop on the afternoon. The exam will take place on December 19. It's a Thursday from 2 p.m. to 5 p.m. It's a written exam. The last 2 years, we have prepared the exam based on an analysis of a publication, which is close of a publication that you will have seen during the workshop. I have put in the Moodle section an example of the exam of 2 years ago, I think. So you can look at it and see what type of question we asked. So basically, it's an analysis of figure and message of a publication, but we may ask some questions that for which the answers have been seen during the workshop. For example, if you have a publication about breast cancer, you will have a publication to analyze, and at the end we can ask some questions about, I don't know, do you know the mechanism of resistance to this type of drug in cancer drug? And this is something you have seen during the workshop. So I really recommend you to be very attentive, even though it's not the workshop where you presented. You have to listen to the other presentation and keep the main messages of the class, of the paper that will be presented by your colleagues. Okay. At the end of the workshop, most of the teacher will do a kind of conclusion with the take-home message. So this is something important to note and to remember. Okay. And so maybe this year we will try to ask a few questions about the workshop and the main messages. Okay, we will not ask something very specific of one publication, but the main messages. Okay. So we are going to start. So my class is a kind of introduction to the pharmacology of anti-cancer treatment. For some of you, maybe it will be very basic, and maybe you will be bored during my class, and that's okay. It's just that because all of you come from very different area, I needed to make something that make everybody on the same level. And also the other objective of this class is to give you some insight of the drug we use in the clinical routine when we treat patients. Because during the workshop, you will see paper very specific to a new type of drug or to a mechanism of resistance. But this is very high-level oncology. And you need also to know the basics, what we do for patients in the clinical practice. So we are going to have an overview of the different types of treatments, and maybe some of you will learn things. And if you have questions, do not hesitate to interrupt me. Okay. So let's start with the basic. The cancer management do not rely only on therapy, even though in our workshop we are going to see mainly drugs. You know that the first treatment of cancer is actually surgery. Huh? Most of the time we try to resect the tumor with the surgery, so it can be a tumorectomy, meaning that we will only take the tumor, and sometimes we will have to take out all the organs. And this surgery can also concern metastasis. In specific case, some metastasis can be resected with the surgery. Then we have radiotherapy. So I guess most of you know that. You can have external radiotherapy with some machine sending some X-ray to treat the tumor specifically. But we also have now internal radiotherapy or internal vectored radiotherapy, where the source of X-ray is given to the patient inside the body to have some radiation in a specific area of the body, and most of the time is within the tumor. Okay. You will have one workshop talking about radiotherapy and specifically on the mechanism of resistance to radiotherapy. And you will have one class tomorrow from 4 p.m. to 6 p.m. with a radiotherapist explaining the principle of radiotherapy. And the last type of treatment, of course, it's what we call chemotherapy or pharmacological treatment. It means that we are going to use some drugs, and we can classify those drugs in 4 types of big area of treatment: the cytotoxics, the hormone therapy, the targeted therapy, and immunotherapy. So we will see the different types of mechanism of action of this class, and we will see some drugs, but there's a lot of drug, and I do not ask you to remember the name of each drug, but you need to know the mechanism of action of all this type of treatment. So maybe you all know that, but what we call cytotoxics, conventional cytotoxics or neoplastic agents, or in French we use the word chemo, is when we use cytotoxic that act on DNA. So this is the common point of all these drugs. They will all target the DNA, okay, the DNA of cells. In a direct or indirect way. So they will interfere with the DNA replication or cell division directly or indirectly. And we consider this is a non-targeted therapy because it acts on all the proliferating cells. So I guess you know that chemo has a lot of side effects. And these side effects are in line with the fact that the normal cells are also affected by the cytotoxic effect. For those for the Master 2 Care students that are online, do you hear me well?
Yes.
And do you see the slides?
Yes.
Okay. The second class is what we call hormone therapy. So this is based on the fact that we will block the proliferative effect of certain hormones on the tumor cells. And we will see we'll see what we are talking about in a second chapter. The targeted therapies are molecules that are directed against specific molecular targets that are expressed in the tumor, but not only, and we will see that sometimes the target of targeted therapy are also expressed in normal cells, but this is a benefit-risk effect in favor of the tumor cells, or the microenvironment. And the last class is immunotherapy, and the mechanism of action of that is to increase the body's immune response against the tumor. So we use the immunity of the patients towards the tumor, because tumor can be recognized as a stranger cell and can be attacked by the immune system. I will put this slideshow on the Moodle section. Okay, so okay, I have prepared, and hopefully it works, a few quiz. So if you agree, you can take your cell phone and scan this code to answer a few questions. Ça marche là? Vous arrivez à scanner? Bonjour, tu peux me donner vos noms? Yes. Yeah. Do you speak English? Yes. Okay. Sorry. Yeah. Okay. I got it. Okay. Yes. I received your email. Votre nom, c'est? Is it okay? Did you scan So you can start answer the question. This is a question where you have to put together the type of treatment that are quoted on the left part of the slide with the definition. Okay, so take your time and try to, if you don't know, it's not a problem, to give some characteristics to the type of treatment I have given. What? So I just started the class with the slides, and the knowledge of students. Yeah, there will be 2 other questions, so if you want to one is there will be 2 other questions in the slideshow. Like you can understand this and you will have access to the question. It's not an obligation. Okay, yeah, it's a problem. Okay, so we still have some, do you still need some time? Okay, so we're gonna look to the answers. Okay, so I gave you a few adjectives corresponding to treatment. So these 4 adjectives are neoadjuvant, adjuvant, curative, and palliative, and you had the definition. So palliative treatment is indeed a treatment to help patients to feel better by decreasing symptoms, but cannot cure the cancer. So I guess most of you find this definition. So it doesn't mean palliative treatment can also be with chemotherapy. Okay, it's not only opioid treatment for pain or stuff like that. We can give a treatment to help reduce the tumor because we think that by decreasing the size of the tumor, we decrease the symptoms that has the patient. Okay, but we know that given the status of the tumor, the patient will not be cured definitely. Okay, so we are in a palliative treatment. So the second term was adjuvant treatment. So 71% of you found the right definition. Indeed, an adjuvant treatment aims to cure the patient in addition of surgery. For the term adjuvant means additive. So this is something that we give after surgery most of the time. And why do we do that? Do you know, is there someone that can tell us why we give adjuvant treatment after a surgery? What's the goal of doing that?
That prevents the occurrence with it. Like if there are some cancer cells which are not killed with the surgery, so to prevent their proliferation again and relapse like this.
Yes, that's the right answer. So I don't know if everybody hears the answer. The adjuvant treatment is there to kill the tumor cells that would not have been taken off by the surgery. Okay, when you do a surgery, you remove the tumor, but the surgeon doesn't have the eyes to see all the tumor cells, and you can also have tumor cells that have started to migrate in other organs or in other nodes, for example. Okay, so these tumor cells will not be removed by the surgery, and we need to kill them with a chemotherapy to avoid a recurrence. Okay, to avoid a long-term recurrence. So this is not an obligation. We don't do it all the time. If the tumor is very tiny and very when the surgeon removes the tumor and then the pathologist look at the slide, he looks at the tumor. If he sees that the tumor is really limited to an organ or to a tissue, and if he thinks that no cells have moved, then it's not an obligation to have an adjuvant treatment. The other term that goes with adjuvant treatment is neoadjuvant treatment. Neoadjuvant, this is the same type of treatment, except that it's given before the surgery. So neo, it means before the surgery. And most of the time, the aim of doing that is to decrease the size of the tumor to make the surgery more successful. Okay? Sometimes if the tumor is very inflammatory, very big, when you see it on the scan, for example, then it's better to decrease the size of the tumor so that when the surgeon will remove it, it will be easier for him. Okay? And a curative treatment is a treatment, a pharmacological treatment, so it can be chemotherapy or targeted therapy that aims to cure the patient without surgery, and definitely the aim is to cure the patient definitely. And so one example of curative treatment is for hematological cancer, like leukemia, lymphoma. In this type of hematological cancer, we cannot have a surgery. The treatment rely only on the use of drugs. Okay, do you have a question about that? So this is just a slide to explain what I said, and this is based on the fact that most of the time, the detectability threshold, so this is when the tumor is, the size of the tumor is high enough to see it or to give symptoms, you can see that the metastases have already started to migrate. And so if you remove only the tumor, you can forget some cancer cells that have started to migrate to other tissue. Okay, another quiz, just to know, to check your general knowledge about history of chemotherapy.
Professor, can you show the QR code again?
Sorry?
Can you show the QR code again, which we can scan?
Okay, yes. Is it okay? Have you had the time to scan the code? So, is it an easy question? No. It's not easy. Is there other students that want to try to answer, or do we look at the results? Okay, so the best choice was the number 3, 1942. And this is the good answer, and I don't know how to the good answer was 1942. It's not easy. I put this question. You will not have a question about that at the exam. It's just because you are going to speak about treatment, cancer treatment, chemotherapy for 2 weeks, and you need to have in mind, like in the history chronological timeline, where we are, okay, and when did we start to treat cancer. So indeed, the answer is on the slide, and we are not going to review everything, but maybe some of you have answered 1918. For one reason. For those who gave the answer 1918, can you tell us why you did answer this question, this reply? Yeah. Can you try to explain?
Peut-être parce que c'est antibiotique.
No, this is not about antibiotics, but there is a link with war. And do you know what is the link between chemotherapy and war? Yes, indeed. It's called the mustard gas. So maybe you have heard that during the First World War, there was a use of gas to kill the other soldiers. And we call this gas mustard gas. Okay. And when after the war, when the scientific analyzed the dead bodies of people that have breathed the mustard gas, they looked in the moelle osseuse. Yeah, merci bonne Caro. And they saw that there were no cells anymore. Like all the progenitors of the bone marrow were dead, no cells. They saw aplasia. Okay, so they start to think that maybe this mustard gas has a cytotoxic effect, was able to kill the cells. And then they made some experiments, and they discovered like the first cytotoxics, which was a mustard drug. In 1942, two researchers, Goodman and Gilman, maybe you know this name because it's the name of a very famous pharmacology book, the Goodman and Gilman. This is like the size of a dictionary, a very big book. So Goodman and Gilman, they started to use a nitrogen mustard drug on a patient that has a Hodgkin lymphoma, and they saw the first tumor regression. Okay, so it was the first use in a human of a chemotherapy type drug. Okay. Unfortunately, they realized that it was not. Like very soon the patient has a resistance to the drug, and then he was not able to be cured. So right after, on the years that followed, the research was focused on discovering other type of cytotoxics and modifying the cytotoxics. And after that, they understand that they need to do what we call combination chemotherapy by giving multiple cytotoxic drugs to avoid the resistance. Okay. So you can remember that 1960s is the time where we do combination treatment. And then 2001 is something that you have to remember in your mind as the first time that targeted therapy was used. Okay, the first targeted therapy agent was used in 2001. And then the timeline is not showing that, but since that time we have every year new targeted drugs that are developed and approved. So we are going to see, you see the outline of the class. We are going to have an overview of each type of drug, and we will start by talking about cytotoxics. So as I told you, cytotoxics, they all act on DNA, and the action can be direct or indirect. For example, direct action is a type of drug that will form some adducts with DNA. So directly on the DNA, you will have a modification of the structure by adding some example adducts. So this is the alkylating agents, for example, or the platinum drug. We are going to see them very quickly in a few seconds. Also, the doxorubicin and daunorubicin, they are anthracyclines, and they have a direct action because they are intercalent drugs, so they act on the DNA. But you can also have some drugs that have an indirect action. For example, they will modify the nucleotide or take the place of nucleotide, and they will interfere with the replication of DNA. And also other drugs that have an indirect action. So all these drugs are called cytotoxics because they act with the DNA. So the target of cytotoxics is the cell with a high proliferation index. So luckily, this is the case for tumor cells. Tumor cells proliferate a lot. So they will be very sensitive to the chemotherapy. But all the normal cells of the body that proliferate a lot will also be affected by the cytotoxic effect. And this is the problem of side effects. We are going to see it in a few seconds. There is something you need to know also about the cytotoxics. They will not act all on the same phase of the cell cycle. So you are all familiar with this figure, I guess, which show you the different phases of the cell cycle. And you know that some cells can be outside of a cell cycle. They not replicate. And we call that quiescent cells. It's a G0 state. So quiescent cells, they will not be sensitive to the chemotherapy, to the cytotoxics, okay? Because they are not replicating, so they will not have any effect of the chemo. For the cytotoxics, we have some drug that acts on specific phase, and we call that drug that are phase dependent, okay? So, for example, a drug can be phase S dependent. Phase S dependent means that it will act especially on the phase S of the S cycle. So, for example, we will see those drugs, anti-metabolites, that are drugs that interfere with the replication step. So it means that they are phase S dependent. Okay? Another example of a phase-dependent drug is the spindle poison. Spindle, c'est le fuseau mitotique, okay? Les poisons du fuseau. Spindle poison, it means that there are some drugs that will inhibit the formation of the spindle and then will block the division of the cells, okay? So, as their name means it, spindle poison are phase M dependent. Okay? So what's the consequence of this? I am telling you that, and maybe you don't know, you don't understand the point. And okay, phase M dependent. So what? When you are going to use a phase, let's say, for example, a phase M dependent drug, for the drug to be active, you need that the cell is into a phase M, okay? But all the cells of the tumor are not synchronized. They are all, maybe some of, when the drug arrives in the body, some cell will be in phase M and other will be in phase S, okay? So those that are in phase S will not be touched by the drug. So what we need to be sure is that at the moment, all the cells will be in the phase M when the drug is still in the body. So what we need to make sure is that when we use phase-dependent drug, you need to have a long half-life of the drug. It means that the drug needs to stay in the body, in the blood, long enough for all the cells to go at a moment into the phase M, for example, in my example. Is it clear? Yes, I will say it again. When you give the drug to a patient, you will have the drug circulating in the body, but you know that the pharmacokinetics will make the drug excrete and eliminated from the body. So the drug will not stay in the body for 2 weeks, okay? Depending on the half-life of the drug can be eliminated very fast or can stay for 1 day, 2 days, depends on the drug, okay? When we use a drug that is phase-dependent, you need to make sure that when the drug will be actually in the body, all the tumor cells will go by the phase, the corresponding phase, okay? For instance, the phase M. So you need to make sure that the drug that you give will stay in the body long enough for the cell to, at a moment, go on the phase, the corresponding phase. Okay, I will give you another example with the phase S dependency. I told you that antimetabolites are phase S dependent. A main drug of the antimetabolite class is 5-fluorouracil. Have you ever heard about this drug, 5-FU? It's a very old chemotherapy, very used in the clinics to treat patients. So the 5-FU has a very short half-time, 10 minutes, okay? It's eliminated very fast by an enzyme. So you just have the drug will stay in the blood for 10 minutes, okay? If you give the drug for 10 minutes, you understand that all the cells will not be in phase S, and the cells that are in another phase, for example, phase M, will not be touched by the drug, okay? So it's not good. So what we need to make sure is that the 5-FU will stay more than 10 minutes. So we will give the drug as a long IV infusion, une perfusion IV, okay? A long IV infusion of more than 40 hours, so almost 2 days of infusion, to make sure that the drug is in the body long enough so that all the cells will go in the phase S and then be touched by the drug. Okay? Is it clear for everybody? So I gave you the example of 5-FU, which is an important one. For the spindle poison, it's not so much a problem because all the drugs of the spindle poison class, they all have a long half-life. So we are pretty sure that all the cells will be at a moment of where the drug is still in the body, will go in the M phase. Okay, so spindle poison, it's okay because they have a long half-life. Contrary to 5-FU, which has a short half-life, and then we give it as a long infusion to make sure that the body is impregnated with the drug during when the cell go in the phase S. Okay? So you have some phase-dependent drug. I gave you a few examples. You can have also what we call cycle-dependent drug. Cycle-dependent drug, it means that the drug will act whatever phase is the cell, okay? It will act on all the cells that are in a cycle. Whatever, it doesn't matter if it's phase S, phase M, J1, okay? So whatever phase is the cell, the drug will act, but it will not act on the cells that are G0 states, okay, outside of a cycle. And the last type of drug is cycle-independent drug. So in this case, it means that the drug will act in G0 state, but also the cells that are in a cycle. So what does it mean that they act on the cells that are in G0? If the cell doesn't replicate, based on the mechanism of action, the cell is not supposed to get to be killed by the drug. What we think and what we know is that in the cycle-independent drug, for example, we can say that for some alkylating agents, they will act on the G0, but they will not kill the cell at the moment. But later, maybe 2 weeks ago, 3 weeks ago, or 1 month ago, when the cell that is in G0 wants to go again in a cycle, then it will be inhibited by the alkylating drug. Okay? So it's a delayed effect, delayed toxicity, that will be visible only when the cells that was in G0 start to go again in a cycle, okay? Another information that you need to know is that tumors may differ in their proliferation index. It means that there is some cancer with a very high proliferation index. And this is the case, for example, of hematological cancer like leukemia. The proliferation index is very important. And that's why the chemotherapy works very well in this cancer. You may know that some leukemia, even though they are very aggressive, chemotherapy is very effective to cure the tumor cells. And this is because this type of cell have a very high proliferation index. In the opposite, some other cancer, like maybe lung cancer, the proliferation index is slower. And in this case, we can expect that the cytotoxic effect is less effective. Okay. So do you think that cytotoxics have a selectivity on tumor cells? So no, I told you that it will act on normal and tumor cells. But also, do you think that cytotoxic are specific of a cancer type? For example, do you think that cytotoxic are specific to breast cancer, other digestive cancer? No, and you know that. So the cytotoxics, they most of the time they are developed not for a specific cancer, just they are developed because they have an action on the cell replication. And what makes the fact that we use a certain drug in colon cancer or breast cancer is because we are doing clinical trials and we see that it's effective on this cancer. So then the drug is approved for breast cancer or colon cancer. But this is not because of the specificity of action of the chemo. And this is something that is very different for the targeted therapies. Targeted therapy, most of the time, they are developed in the aim to treat a specific target, which is expressed in a specific cancer. And so I have put here in the slide the cell that we consider to have a high proliferation index in the body. And this gives you an overview of the side effect that we observe with cytotoxics. So cells with a high proliferation index are tumors, of course, and this is pretty good because this is what we want to treat. But we also have bone marrow cells that have a very high proliferation index, and this is what we call myelotoxicity or hematotoxicity, and this is why all the cytotoxic will provoke neutropenia, thrombopenia, anemia. Okay, we have a decrease of the hematopoietic cells. They have an effect on the hair follicle, which cause for some drug alopecia. The epithelium of digestive tract is also some cells that have a high proliferation index, which creates all the digestive toxicity, such as diarrhea, nausea aussi, as well. Mucositis. Mucositis is an attack of the mucosa area, such as mouth and inside of donc la cavité buccale, toutes ces muqueuses. And specifically, when you have a mucositis, like people have trouble to eat because it's very painful. But it can also affect other mucosa. And we can have sterility because of the effect on cells of the reproductive organs. So most of the time, if people want to have children, we will propose them to keep their spermatozoid or ovocyte for them to be able to have kids after the chemo. Okay, so let's start another quiz. So this one can be tough because I put some drug names. So if you know them, then you try to answer. If you don't know, it's not a problem. It's just for me to see what if you already know this drug. Do you have a biological background?
I am from bioengineering, but I don't know about it. But I'm before but nothing. Not there.
Est-ce qu'on vous avez encore un peu besoin de temps ou do you need more time or can we look at the answers? So maybe so did you recognize any names? Okay, are there some students that don't know any of these drugs? And that's okay because you have very different backgrounds. So maybe some of you don't know at least. Do you have some tricks that you can share to be able to classify those drugs into this class? Tricks is like astuce or like some general knowledge, even though you don't know the drug, the specific effect of the drug. Is there something in the name of the drug that can help you to be able to make a link with the class? Yes?
When it ends with MAB, it's an antibody, so it's an immunotherapy.
So the beginning of the sentence is correct. When it's finished with MAB, means monoclonal antibody. MAB, monoclonal antibody. So when we use a monoclonal antibody, it means that we will target a specific protein, a specific receptor, for example. So MAB can be immunotherapy, you're right. But what else can they be? They can also be targeted therapy. And for instance, bevacizumab is a targeted therapy against VEGF, so a factor, okay, which is not involved in the immune response. But very good, it's a very good point. Do you have other? Did you have other way to make any connection? Say it again. In? No, so you're right. Cisplatin and doxorubicin are cytotoxic, and maybe I don't know about it, but I don't think there's a link with the fact they are cytotoxic.
The tyrosine kinase so it is quite also inhibit.
Okay, yes, it's also a trick. Inhib. So maybe you have recognized the inhib terminology. So inhib means there are small drugs that inhibits the tyrosine kinase effect and domain. So we will talk about that later. But so we can. So what's the class of imatinib, for example?
Targeted or
It's targeted therapy. Okay, very good. So let's look at the answer.
No,
Sorry. So let's look at the answer. So doxorubicin, indeed, we are going to see it. I just wanted to check if people, what was your background before I explain to you. Doxorubicin is a cytotoxic, is an anthracycline acting as an anticoagulant agent. You will see it. Imatinib, indeed, this is an inhib drug which have an effect on the tyrosine kinase domain, and most of the tyrosine kinase inhibitors are targeted therapy. Tamoxifen, there was nothing to help you to know that. The only thing is maybe you have seen it in your class before. Tamoxifen is a hormone therapy, and we will talk about later. Bevacizumab, so we already talked about that. This is an antibody, but it is not immunotherapy. It's directed against VEGF, the vascular endothelial growth factor. And this is something that is involved in the angiogenesis, so the formation of blood vessel to the drug. And so this is a targeted therapy that is used in cancer to inhibit the angiogenesis. Enzalutamide, it was a very tough one. So maybe for only that already work in a cancer center or know the drug. It's a hormone therapy also, but it's directed, it's for the, well, we will see that later. Cisplatin. Cisplatin is a very old cytotoxic drug, and we will see it. There is a class of platinum derivative, and they are all cytotoxics because they are forming some adducts on the DNA, so they act on the DNA. And nivolumab is also a monoclonal antibody, but this one is indeed immunotherapy, because we will see that it acts on it will boost the immune system to eliminate the cancer drug. Okay? So let's see the main cytotoxic mechanism. So in the blue line, you will see the main class of cytotoxics. I really say the main class, but there are also some other drugs that are miscellaneous, like they are alone in their class, or they have not typical mechanism of action, and there's a lot of them. So I decided not to talk about them, and I will just show you the main mechanism. So the first one, it's in French, sorry, alkylating agent, or platinum derivative. So the alkylating agent is what derive of the mustard gas that I mentioned earlier, the mustard drug. So they were the first one to be developed. And the mechanism of action is it's what I mentioned earlier. They are capable of forming adducts. So for alkylating agent, we call them alkyl adduct or platinum adduct for the platinum drug. And they will form this adduct by doing a covalent bond between the DNA and the drug. Okay? So this adduct can be very different. It can be monofunctional. It means that one drug will just make a bond with one base of the DNA. Okay. But most of the time, these drugs are capable to form two covalent bonds, so they can do what we call bifunctional adducts, and they can create a bond that can be in the same strand of DNA. No, in the same strand, merci. In the same strand of DNA, so this is intra-strand, and they can be inter-strand when they are not in the same strand, okay? And they can also form some adducts on two DNA molecules, okay? And also they can create what we call a bond between a protein and DNA. So these drugs are very reactive, and I don't show you the chemical mechanism of action, but they are very reactive, and they will interact with bases or protein to form this bond. So the consequence of this, of course, you can imagine, it's that it will interrupt the transcription and the replication of DNA, and it will put the cell in apoptosis, and the cell will die. So this slide is just to show you that there is a very big class of drug, and I don't need you to remember the names. It's just that if you maybe you have already heard some names of drug, and then you will be able to see them in the list. But I don't ask you to understand that. I just show you the chemical structure of the cyclophosphamide, which is a mustard drug, and this green component is with the floor here. This is what actually is reactive. So you will have one bond created with this one and one bond with the other one. Okay, so this is the reactive component. What you need to know about this drug is that some of them are very interesting because they are very lipophilic, and they can cross the blood-brain barrier. This is something that is very interesting in oncology, because you know that some cancer are located in the brain, cancer or metastase, and we are very limited in the drug we can use, because most of the drugs are blocked by the blood-brain barriers. So when we want to treat cerebral tumor, we need to get some drug that will cross the blood-brain barrier, and those drugs are able to do it. Okay. Last thing I wanted to say is that this drug, they have multiple indications. This is because they are very old and very effective. So they are very used in hematological cancer. Most of the chemotherapy protocol in leukemia or lymphoma, they all include an alkylating agent. But also numerous solid tumors, breast, ovary, sarcoma, brain tumors. So just you just have to remember that this is not because they are old that they are not used anymore. This is very useful. Okay. For the platinum derivative, so as I mentioned, they can be most of the time in the books, for example, they are mixed with the alkylating agent because they have the same mechanism of action, forming adducts on the DNA. However, we cannot call them alkylating agent because the adduct they are going to create is not an alkyl chain. Okay, I don't know if everybody has basics in chemistry, but alkyl means that you will have some carbon and hydrogen atoms, and you can see that in the platinum adduct, you have a platinum atom. So that's why they, if we want to be very rigorous, platinum derivative are not called alkylating agent because they are not forming alkyl adducts. Okay, they are forming platinum adducts. So you have three drugs that are in this class: cisplatin, carboplatin, oxaliplatin. They are easy to recognize with the platinum term. And so the cisplatin and the carboplatin are very similar because when they are given to the patient, when they arrive in the blood, they will have there will be a hydrolysis of the drug, and they will give what we call diaquaplatin. This is the active metabolite. Okay, and this active metabolite you see has a 2+ charge, which makes him able to interact with DNA and form some adducts. The oxaliplatin is quite different because you can see that the adduct is more bulky. You see here, it's a very big adduct compared to the small adducts formed here by carboplatin and cisplatin. Okay, so the oxaliplatin adducts are more cytotoxic than the cisplatin or carboplatin adducts, but it will form less adducts, so it's a good balance. What you need to know is what's important about platinum derivative is that, and it's also true for alkylating agents, at least for this, for the main resistance mechanism. As soon as there is an adduct on the DNA, you know that some DNA repair mechanism will be involved to remove the adduct. Okay. So this is something that happens when there is a problem in the DNA. So you can have different types of problem, single strand break, double strand, bulky adduct. So this is our case here, or also mismatch and insertion deletion of bases. So in the case of bulky adduct, the mechanism that will be recruited is a nucleotide excision repair mechanism that you may have heard in your previous class. So nucleotide excision repair. So I'm not going to detail that, but a lot of protein are going to recognize the adduct and repair the DNA to give a DNA that is that has no adduct anymore, and the cell is saved. Okay, the cell will not die because the DNA has been repaired. So you understand that this is something that will be opposite of the effect that we want to have. We want to kill the cells, but the nucleotide excision repair mechanism will repair the cell, and then the cell will not die. But so this is a mechanism of resistance, very important, the reparation of DNA. And this is why most of the time we give the cisplatin with other drugs because it can be not effective enough because of this resistance. And there is one very interesting case. This is also something maybe that is more historical for you to know than than pharmacological. But in a long time ago, the introduction of cisplatin in the treatment of testicular cancer was a revolution. It increased the response rate from 5% to 70%. And the main reason is because this specific tumor express very few nucleotide excision repair protein. So the NER is almost not existing. Therefore, there is no resistance, and then the treatment is very effective. And testicular cancer, and it's a cancer that affects young men, but most of the time they are cured thanks to cisplatin. Okay. So if we go a little bit further in the difficulty, there is another mechanism of repair that is involved in the reparation of platinum adducts. And this mechanism is what we call the mismatch repair, MMR. MMR means mismatch repair. But in this case, it's different. When the MMR recognize a platinum adduct, like here, when the MMR recognizes a platinum adduct, it will put the cell in apoptosis. So it will kill the cell. So in this case, this is not a mechanism of resistance. It's a mechanism that helps the drug to be effective. Okay? It increases the activity of cisplatin. So this is pretty interesting. However, the MMR recognizes the adducts that are produced by cisplatin and carboplatin, but it does not recognize oxaliplatin. So what are the consequences of this? It means that when you treat patients with cisplatin or carboplatin, the MMR will help the drug to be active. Okay? For the oxaliplatin, the cytotoxicity of the drug do not rely on MMR because it doesn't recognize the drug. In oncology, we have certain type of cancer, and especially colon cancer, that are MMR deficient cells. So this is what we call the MSI phenotype, microsatellite instability phenotype. And so this cell doesn't have any MMR. Consequently, we consider that they will be resistant to cisplatin and carboplatin because the action of the MMR that normally put the cell in apoptosis will be absent. Okay, so in this case, the cisplatin and the carboplatin cannot be effective in the MMR deficient cells, whereas the oxaliplatin that doesn't need MMR to be active will have an efficacy in this type of cancer. Do you understand that? Okay. And this is why am I talking about that? So maybe it's more for people that we treat patients or see, but it means that you cannot replace oxaliplatin with cisplatin or the other way because they have mechanism of action quite different because of that. And especially in colon cancer, maybe if some of you are doctors, you have already seen chemotherapy protocols. In colon cancer, we use oxaliplatin because of this, but we cannot replace the oxaliplatin by carboplatin because it's not going to be effective. Okay? So just for you to remember that the DNA repair mechanism, most of the time they increase the resistance because they repair the cell, but in the case of MMR, this is the opposite. Second type of cytotoxic that we can mention is anti-metabolites. So I don't know, maybe have you ever heard about anti-metabolites? Everybody knows this drug. So these are drugs that are structural analogs of metabolite present during the cellular metabolism. They will inhibit the synthesis of DNA, but also RNA by taking the place, substituting this intermediate. So most of the time they are very hydrophilic drug. They will get inside the cell. They will be transported inside the cells, And when they are inside the cells, they look pretty much as an endogenous nucleotide, for example, but they have a change in the structure that makes them produce. On dit que c'est des substances frauduleuses, hein, qui prennent la place des antimétaboliques normaux. And so, based on their mechanism of action, these compounds are very active in tumor with a high proliferating activity, and they are phase S dependent. This is what we mentioned in the beginning of the class, because they specifically act on the replication phase. So this is also a very big class of agents. And in red, you have the main one. And again, I don't need you to understand and to remember the name, but maybe you will recognize some names. And there are three main classes. The anti-folate means that those drugs mimics the structure of folic acid. Okay, and we will see how it works. Then you have purine antagonists. It means that they are drugs that are very similar to purine bases, such as adenine, guanine. And you have pyrimidine antagonists. It means that those drugs are similar analogs of cytosine, uracil, or thymic. Okay. So let's just see the mechanism of action of methotrexate. This is a very old chemotherapy, but it's still very used in the routine treatment. So methotrexate needs to enter in the cell by a specific transporter, reduced folate carrier, RFC. And then once it's in the cell, it's going to inhibit a specific enzyme, the dehydrofolate reductase, which is involved in what we call the cycle of folate. So I don't know if you remember this. I guess you have seen it in your first year of biological studies. This cycle of folate starts with the use of folic acid. And the aim of this cycle is to give a methyl here, a CH3, a methyl, to be able to transform the DUMP into DTMP. And the DTMP is necessary for DNA synthesis. So if you don't have DTMP, the DNA synthesis will stop. And then the cell will die. So the dehydrofolate reductase allows the transformation, the reduction of dehydrofolate into tetrahydrofolate. And then the methotrexate inhibits this enzyme. Therefore, the consequence of this is that this thymidylate synthase doesn't have any CH3 to transform the DUMP in DTMP, and there is a DTMP depletion that can kill the cell because the DNA cannot be synthesized anymore. So this drug is used in hematology cancer, like acute lymphoid leukemia, non-Hodgkin lymphoma, but also solid tumors, and this is something that is very used still, although it's an old drug. I squeezed the second class, and just to show you the pyrimidine antagonist, and especially the 5-FU that we mentioned earlier. So you can see the 5-FU is just a uracil molecule, with a fluor that is added. And the fact to have this fluor here will inhibit the synthesis of DNA, because the structure does not allow to synthesize and to add any other nucleotide after this one. So it will stop the replication and it will kill the cells. The capecitabine is a prodrug, is an oral prodrug of 5-FU. So you can see here we can find the 5-FU structure. And once it's given to a patient, so this is interesting because it's an oral drug, so the patient can take it at home. It doesn't have to come at the hospital. And once in the body, it will be metabolized to give 5-FU. So the effect is the same than 5-FU. And here you have the analogs of cytosine. So here there is a small difference. The base is the good one. You see that the structure of the base is not modified. And what is modified is actually the ribose. Okay, the sugar here. The hydroxyl are put in trans instead of cis, and this will inhibit the synthesis. Anyway, just to show you that they are very small drugs and they are similar to endogenous analogs. So these are anti-metabolites. You have to remember that they are phase S dependent. And again, these drugs are very used, and especially the 5-FU, notably in digestive cancer. All the colorectal treatment contain 5-FU, for example, but also other cancers. This is an example of a protocol that is widely used, the FOLFIRI. So this is a combination. FOLFIRI corresponds to the abbreviation of, I don't know if you know that, of the drugs that are used. The FOL is for acid folinic. So I didn't mention it, but this is something that increases the effect of 5-FU. So acid folinic is not a chemotherapy. It's only a drug that increases the effect of 5-FU. 5-FU infusion ici, and IRI is for irinotecan that we will see right after. This is another type of drug, another type of cytotoxics. So it's given together. We start with the irinotecan and then the 5-FU infusion. And you can see the 5-FU is given for 46 hours as an infusion. And you remember why? Because it has a small half-life, as I mentioned earlier, and since it's phase S dependent, it needs to be in the body for a long time. So that's why we give it like this. And for capecitabine, the oral prodrug, this is something that is given for 15 days every day, and then there is a week where the treatment is stopped, and then the patient starts again. And this FOLFIRI treatment is given every 21 days or 15 days. This is for me the occasion to talk to you about the administration of cytotoxics. What do you know about that? What is the reason to which we give the cytotoxic? Do you think the patient takes the drug every day for 2 months, 3 months, 4 months? Is it given as cycles? Yes, cycles. And why? What's the reason to give the drug as cycles with some window where the patient doesn't take any treatment?
I don't know patient because neutropenia.
Yes. Is there other proposition? And I will say it louder. Do you know why?
Pour laisser le temps au progéniteur de se reconstituer dans la.
Yes, exactly. So the cytotoxic are given as cycles, like with 15 or 21 days without treatment, because it's very toxic for the hematopoietic cells, okay, for the bone marrow. So if you give as a permanent treatment, you will kill the bone marrow cells and you will put the patient in aplasia with no white blood cells, no red cells, and it's a very critical state. And so you need to have some window without treatment so that the bone marrow can start again to produce hematopoietic cells, and then the patient will again have some white blood cells circulating in the body, and then is not at risk to get an infection or to have other issue. Okay, so this is true with all the cytotoxics. I don't know any cytotoxic that is given every day without any stop because it's too toxic for the bone marrow. Okay, this is something that will be very different with the targeted therapy, for example, where we don't have this problem. Okay, is it clear for everybody? Next class is intercalants, intercalating agents. So we already mentioned a few drugs, and you can recognize them because they come from the same family, and they finish with the rubicin term: doxorubicin, donorubicin, epirubicin. So these drugs are very big drugs. You can see the structure here. We have 4 cycles that are attached, and this chemical structure gives them a structure that we call in French is coplanaire. It means that they will be in the same plan. And so this is a very bulky molecule that will, as their name mentioned, intercalate into the DNA. Okay, so this is in line with the chemical structure. You can see in this slide the intercalating agent will enter into the double helix of DNA, and it will intercalate here. And so the consequence of this are multiple. The first one is it will modify the 3-dimensional structure of the DNA, so it will interfere with the replication transcription mechanism because of the modification of the 3-dimensional structure. And also what we know that is that the fact to have this intercalating agent in the DNA, it will inhibit the effect of topoisomerase enzyme. Topoisomerase enzyme, we will see them in a moment. I guess you know this type of enzyme. They are necessary for the replication. They help the DNA to deconvolute the spiral, so to decrease the strength of the DNA helix, and so they are necessary for the replication to happen. So now we know that anthracyclines, they are able to inhibit the effect of topoisomerase 2, in addition of their mechanism of intercalation. And so these drugs are coming back to are also very used drug in various treatment. It can be solid cancer or hematological cancer. Another class of cytotoxic that is very important is then topoisomerase inhibitors. Then you can have 2 types of inhibitors: topoisomerase 1 inhibitors or topoisomerase 2 inhibitors. It depends on the type of topoisomerase that they inhibit. Topoisomerase 1 is I'll see. So the mechanism of action of topoisomerase 1 or 2 is to the mechanism of action of topoisomerase enzyme is to so you know when you have the double helix of DNA, there's a lot of strength on the helix, so it's not possible for the replication fork to work on the DNA like that. So the role of topoisomerase is to cut one DNA strand, okay, to remove one turn of the helix, and then to religate the DNA. Does everybody know this mechanism of action of topoisomerase? Okay.
Je sais pas pourquoi vous avez mis, j'ai mis un schéma.
Ok, donc je dis en français un coup, les topoisomérases, ce sont des enzymes qui enlèvent les forces de torsion de la double hélice d'ADN. Ok, sinon la fourche de réplication ne peut pas avancer. Donc elles vont couper un brin, enlever un tour de la boucle d'ADN et recoller. Comme ça relâche un peu la pression et la fourche de réplication peut avancer. Ok. Les topoisomérases 1, elles coupent un seul brin, et les topoisomérases 2 sont capables de couper les deux brins. Et à chaque fois, elles religuent. Okay. Did you understand what I said about topoisomerase enzyme action?
Yes.
So is it okay? Okay. So the topoisomerase inhibitor, what they do? They come and they let the topoisomerase cut the DNA. So the topoisomerase can cut the DNA, but the inhibitor inhibits the religation step. So it means that the DNA will remain with one break in the strand. Okay, and this is not good. Having a break in the strand can be very negative for the cell, especially if you have two breaks. Okay, so the topoisomerase inhibitor, they inhibit the relegation step, and then it causes a definitive cut in the DNA strand, and the cell will die. Okay. So we have two types of inhibitors: the topoisomerase 1, and the most famous drug is irinotecan. Topotecan is less used now. And topoisomerase 2, we have especially one drug, the etoposide, that is very active and is used in some chemotherapy regimen. And also the anthracycline that I mentioned just earlier, they are considered as topoisomerase 2 inhibitors. Okay? So about their use in cancer, so irinotecan is a very specific of digestive cancer. So it's used in colorectal cancer, pancreatic cancer also, in combination with 5-FU. This is the protocol we saw before, FOLFIRI or FOLFIRINOX, when you have oxaliplatin in addition. Topotecan is less used than it's used in ovarian cancer or lung cancer. And for etoposide, it has a large area of treatment, since it's used in solid cancer, but also hematological cancer, and also in oncopediatrics. So for the children cancer that are sometimes very aggressive, etoposide is most of the time included in the chemotherapy protocol. And to finish with this cytotoxic class, we can have spindle poison. So as I mentioned earlier, spindle is the fusomitotic. So this drug inhibits the formation of mitotic spindle and the maintenance of cytoskeleton. So this is an inhibition of the mitosis. This is quite different than what we saw before. So it's a phase M dependent drugs. And we have two main families of inhibitors. Inhibitors that are Venka alkaloids. It means that these are alkaloids that are extracted from a flower, the periwinkle, pervenche en français, hein, c'est les alkaloïdes de la pervenche. So with drugs that you can recognize because they all start with Vin as Vinca. vincristine, vinblastine, vinorelbine, vinflunine. And the second class is taxane, and they also derive from a natural product that was found in the middle of If occidental, specific kind of tree. And now these drugs are obtained by hemisynthesis from a natural product taken in the needle. And the most famous drugs are paclitaxel and docetaxel that are used in many cancers. And the difference between those two types of drugs is that they are all spindle poison, but they do not inhibit the same step, the same action. For the alkaloid of periwinkle, they will inhibit the polymerization of tubulin dimers that lead to the formation of microtubules. So I don't know if you remember that, but the spindle is composed of tubulin, and this tubulin is growing with the polymerization of dimer de tubulin here that is going to make the spindle increase. Okay, so when the spindle increase, it means that you have a polymerization of tubulin dimers, and this is inhibited by the alkaloid of periwinkle. So we call them inhibitor of polymerization, tubulin polymerization, whereas the taxane inhibit the depolymerization of the spindle. It's when the microtubules are shortened during a depolymerization. So here again, just a slide for your information, not to memorize, just to show you the different indications that can have this drug. So you can see that the Venca alkaloids are very used, and especially in pediatric cancer. Paclitaxel and docetaxel have a lot of indication in solid tumors. And for the last two drugs, because they are more recent, they have less indication, because since they are more recent, they didn't have the time to make many clinical trials in different areas. So there are less indication, but maybe in 10 years, there will be more indication, because we would have the time to do the phase 3 trial. Okay, I suggest we finish with 1 or 2 slides about cytotoxic, and then we will have a break, okay? So just the principle of chemotherapy. So I guess we have talked about most of them, but what are I show you many drugs. I told you that they are indicated in many cancers, but how do we choose? How do we do to select a protocol? So we use the most adaptive drug, but for chemotherapy, for cytotoxics, there is no really scientific rationale for choosing one from another. And most of the time, this is based on the preclinical results on the tumor cell, or in the preclinical studies with mice. You see which tumor seems to be the most sensitive, and then you say, okay, this drug seems to be very active in breast cancer. Let's try it in breast cancer. The other principle is that we use the maximum tolerated dose. So, do you have any background in the phase 1 study, the phase that is necessary to find the dose that we are going to use in patients? Does everybody know how it works? A phase 1 study? Yes. Okay. So you know that we try some dose level. And we look at the efficacy or toxicity. So for anti-cancer drug, what we do is we use the most higher dose that is tolerated by the patient. So we don't choose the efficacy, we don't choose the dose based on the efficacy, we choose the dose based on the toxicity. Okay, we take the most tolerated dose, okay, even though a lower dose was effective, because we consider that for chemotherapy, more is better. So we need to give the highest dose, okay? We use consecutive cycle, and we already mentioned the reason why, and this is to avoid the toxicity and to let the bone marrow recover from the toxicity of the chemotherapy. And we combine drug with different mechanism of action. So for instance, we can combine an alkylating agent with an anti-metabolite with a spindle poison, okay? But we need to pay attention to the toxicity. I didn't want to give you too much information, but all the drugs that we have seen, they can have specific toxicity except the hematotoxicity. For example, they can be nephrotoxic for the kidney, for example. So we are not going to put together two nephrotoxic drugs because we know that it can be very bad for the patient. And about the dose that we use, we try to individualize the dose, but this is very basic. Most of the time, the dose individualization is just based on the body size. So it can be square meter for the body surface area. Okay, so we can calculate the body surface area of the patient. It's based on the weight and the size. Or we can calculate a dose that is milligram per kg, so based on only on the weight. We can also have some adjuvant therapies that can prevent the toxicity. I'm not going to mention them. So we talked about toxicity already. So I just wanted to warn you about the hematotoxicity. And also, I already mentioned that, but there is a very high level of, there can be a very high level of resistance, and this is why we use combination treatment. So what can be the reason for a tumor to be resistant? It can be the way to be in a G0 state, as I told you already. Except for a few drugs that are cycle independent, but most of the drugs of the cytotoxic works in a cycle dependent way. So it needs the cells to be in a cycle. You also have dedifferentiated cells, which is quite the same problem than G0 cells, means that they will not be sensitive to the treatment. There is the problem of polyvascularized tumor. It means that if there is no blood vessel going to the tumor, then the drug cannot access the tumor. So this is, in a way, this is a way to resist to the treatment. And we can have the development of resistance mechanism, specific resistance mechanism. I already mentioned the base excision, the nucleotide excision repair with cisplatin. This is one type of resistance, and we'll see later in this lesson. We'll see other type of resistance mechanism. Okay, so we can have a 10-minute break if you want. Wow. Elle a eu un problème de voiture, ça lui a fait la répétition. Alors, en général, c'est pas développé. Plutôt chez des. Alors, ça peut être réversible, hein. Voilà. C'est pas forcément facile. On sait quand même qu'il y a une chance d'avoir des choses comme mais chez les enfants, alors oui, non, mais c'est sûr que c'est post-liberté, c'est sûr que je l'ai des molécules qui rendent le sourd ou des choses comme ça. Non, c'est ça peut être. Mais tout ce qui est lié à la cellule, là, mais si par exemple, les cheveux rouges, les cellules là qui sont très affectées par la chaleur, parce qu'en fait, c'est une connexion de sécurité. Mais bon, c'est quand même c'est comme chez les patients, voilà.
Cibler, faire en sorte que je fasse oral rentre en M pour éviter de faire entrer de
c'est sûr, ça ne se fait pas en donc je trouve que ça, il y a des essais qui ont essayé de faire synchroniser les cellules.
pour un organe spécifique.
Ouais, ça peut avoir quand même des conséquences. Ça a des conséquences de base du tout. Et pas on va être c'est normal, mais peut-être qu'on n'a pas été oui, peut-être que ça me semble. C'est bien qu'on c'est un antimétabolique qui agit au moment de la méthylation thermale.
Ouais, moi, je me fais une fiche. En fait, je me souviens, je rentre
En fait, le terme métabolique, ça fait référence au métabolisme endogène, par exemple, les tout ça, c'est nos métaboliques endogènes qui sont nécessaires à l'évaluation. Il y a des antimétaboliques, c'est une analogue à ces métaboliques. Et avec, il y a avec ces analogues, on les appelle des comme la place, les vrais métaboliques, genre, j'ai pas pris ça.
C'est bien. Sur le reste de la
En fait, ça dépend. Genre là, les infections, s'il y a été mis à deux, et des contraintes. C'est ça, ils ont besoin bien. Et du coup, et encore, on va faire ça. Et après, je
Allez, on va reprendre. So now we are going forward in the different types of therapies. And we are going to talk a little bit about hormone therapy. So what do you know about hormone therapy? What are the cancers that can be treated with hormone therapy? Breast cancer and prostate cancer. Okay, so maybe you all know about that and we can go fast on this part. And for breast cancer, what type of hormone therapy are we going to use? So estrogen, like anti-estrogen or pro-estrogen? Do we want to inhibit the effect of estrogen or do we want to increase the effect of estrogen? Inhibit, okay? So estrogen can have a proliferative effect. So we want to inhibit the estrogen effect in breast cancer. And what about prostate cancer? What type of hormonal therapy do we use? Okay, so same question, is it anti-androgen or pro-androgen? Anti-androgen, so same model. Androgens in prostate cancer have been shown to increase the proliferation of prostate cells. So we want to use anti-androgens. Okay, so you all know about that. Maybe there's a subtlety between the difference between breast cancer and prostate cancer is that for breast cancer, do you think that we treat all the breast cancer with hormone therapy? Yes. So indeed, in breast cancer, we need to make sure that the cancer cell express the estrogen receptor and progestin receptor. Okay, so it's what we call ER plus, PR plus. It means positive for estrogen receptor or positive for progesterone receptor. Okay, and only if when the pathologist analyzes the tumor, only if there is an expression of this specific receptor, then we will consider that the tumor is hormonodependent tumor, and then it will be treated with hormone therapy. Okay, so some breast cancer are not treated with hormone therapy because they do not express the estrogen receptor. For prostate cancer, it's quite different. We consider that all prostate cancer have are androgen receptor dependent, at least at the discovery of the disease. So the first line treatment, most of the time, is based on hormone therapy. We do not look at the tumor to see if it expresses the receptor. The first line treatment is based on anti-androgen therapy for prostate cancer. Okay, and then if the tumor does not respond to the treatment, we can have access to other drugs. So this is the main difference between those two cancers. So I guess all of you know that these are the effects of estrogen. So the general effect. So you can see that most of the effects of estrogen are positive effects, except the cancer effect. It's now well known that the estrogen can increase the risk of breast cancer and endometrial cancer, and this is why we can use hormone therapy. Just also a small, short reminder, the estrogen receptor that we want to inhibit, I mentioned to you that they are nuclear receptors. They are not located on the membrane of the cell. And when the estradiol enters the cytoplasm, it will recognize the receptor that is in the cytoplasm, and then all the complex estrogen receptor can translocate into the nucleus, and they will act by stimulating some specific area of the DNA, most of the time in the promoter region of a specific gene, and they will increase the gene transcription of estrogen-dependent gene, and this is why they act. So we are not going to go through all the classes of anti-estrogen, but we have different types of drugs that can be used, and we can act at different level of the synthesis of estrogen. So you may recognize the hypothalamo-hypophyso axis. So starting from hypothalamus to hypophyse, and then on the ovary, you have the synthesis of estrogen here. So we can act on different levels of this cascade to inhibit the estrogen. So the most straightforward way to inhibit the estrogen is to use anti-estrogen, and you will recognize the tamoxifen. So it's considered as anti-estrogen, although its mechanism of action is quite complex. It's what we call a modulator, depending on the tissue where it binds to the ER, the estrogen receptor. It can have different effects. It can be agonist or antagonist. So it's not like a real inhibitor. It's more a modulator of action. But in the breast, it will have an effect of antagonist, and this is what we want. So in the breast, it will inhibit the effect of estrogen. We can also have anti-aromatides that are used, especially in women, in postmenopausal women. So we have 3 drugs: anastrozole, letrozole, exemestane. And so what they do, they inhibit aromatase here, which is an enzyme that is necessary to transform the androgen into estrogen. This is particularly effective in postmenopausal women. In postmenopausal women, you know that the ovary doesn't work anymore, so it doesn't produce any estrogen. But we still have a very small production of estrogen in certain tissue. For example, in adipose tissue, also in the mammary cells, you have a small production of estrogen, and this small production of estrogen comes from the action of aromatase on androgen, and these androgens are produced by the surrenal, by the surrenal glands that are producing androgen. So we have also, even the women, we have androgen circulating, and then the aromatase transform this androgen into estrogen, okay? So in postmenopausal women that would have cancer, breast cancer, we want to specifically inhibit this production of estrogen, and we use anti-aromatase, okay? But aromatase is also involved in women before menopause, and so in some protocol we can use anti-aromatase also in premenopausal women. And the other way to inhibit the synthesis of estrogen is to act earlier in the cascade on the receptor of GnRH. And we use for that GnRH analog like leproreline or goserelin. So this GnRH analog, they will act on the GnRH receptor, but they will have a mechanism of action that is quite different than GnRH. If you remember how this works, the GnRH that is liberated by released by hypothalamus will act on this receptor, and it will activate the synthesis of FSH, LH, and the synthesis of estrogen. So you may wonder why we are going to use an analog of GnRH that is something that will have a positive effect on the synthesis of estrogen, and this is not what we want. Are there some of you that knows how the GnRH analog works to finally inhibit the effect of estrogens? This is a tough question. No, it's not a negative feedback, but that's a good proposition indeed. So I'm going to try to help you. This GnRH analog, so they are agonists of the GnRH receptor, okay? But they are very powerful. They have an activity that is much higher than the GnRH itself. Do you know what's happening when you put an agonist with a very a good affinity and a very important power on some cells expressing the receptor of this agonist. What can happen?
They will bind instead of the endogenous compound. But they will be more.
Yes, so they will take the place of the endogenous compound. But if they activate the pathway, then the effect might be the same. Yes. Yes. Do you know how this is called? Yes, desensibilization. Desensibilization is the fact that when you hyperactivate some receptor, the signal is so high that the cell will internalize the receptor to decrease the signal. Okay, so desensibilization is the fact to internalize the receptor, so the receptor is not expressed at the membrane anymore, and then even though you have a very powerful agonist, it cannot act on the cell. Okay, and so what happened in this case? It's exactly what you mentioned. On the first day of treatment, you have a very powerful effect, and you will see the estrogen increase very high. Okay, so that can be dangerous. So it is recommended when you start a GnRH analog treatment to use an anti-estrogen treatment in the meantime, because you will have a high level of estrogen, so you need to inhibit all the receptors, and especially the ones that are expressed in the tumor, because you will, otherwise you will make the tumor proliferate. So you use an anti-estrogen, and during the first week of treatment, you will see a very high level of estrogen. But then you will have the mechanism of desensibilization. It means that on the hypophyse, all the GnRH receptor will be internalized, and then there will be no receptor anymore. So the GnRH, the endogenous GnRH or the GnRH analog cannot stimulate the hypophyse, and then you will see in a second time a decrease of the expression of estrogen. This is what we call a pharmacological castration. Okay, this is very effective, and you do not express any hormone anymore. So it's true with estrogen, but it's also true with androgen. So this treatment, the GnRH analog, they can be used also for prostate cancer. So this GnRH analog may be used, for example, in premenopausal women, when we need to really block, depending on the cancer, if you need to really block any estrogen source, you can use these GnRH analog that are very powerful in addition to anti-estrogen. Okay. So these are the main classes of hormone therapy. And do you have any idea of how hormone therapy in cancer is used? For how long do you think the treatment is given?
5 to 10 years.
Yes? So I guess you're an oncologist. So indeed, this kind of treatment is given in a long time, for 5 years, or sometimes 10 years. Okay, and it's not the first treatment that we give to the patient. In breast cancer, as I mentioned earlier, most of the time you will have a surgery. Then, if necessary, we give adjuvant chemotherapy. And then, depending on the tumor, does it express hormone receptor or not, you will start a hormone therapy for 5 years. Okay? Alors, it's what we call first intention, or it is a first intention. Like it's not the first one in the chronology of treatment. but it's still given in the first intention of treatment of hormone-dependent cancer. Okay, what we call second intention or third intention is more when the first treatment cannot be given, or if the patient has recurred, what would be the second intention or second line treatment. Hormone therapy is the first line treatment for hormone-dependent cancer, breast cancer. Okay. And even though these treatments are less toxic than chemotherapy, you need to have in mind that it's not easily tolerated by patients, and some women do not tolerate this treatment, and it's like complicated sometimes to keep the treatment work for 5 years. So for prostate cancer, if we take the same figure, you can also have different way and different level where you can inhibit the androgen effect. So the first treatment and the most straightforward are anti-androgens. So you have many drugs. Sorry, they are all called with glutamide, bicalutamide, nilutamide, and the more recent drugs are here in brown, like enzalutamide and apalutamide, darolutamide. So these are very effective second generation anti-androgens, whereas the two first are first generation. So these drugs are more simple than tamoxifen. They are real antagonists. So they are just they bind to the androgen receptor and they inhibit the effect of androgen. They are not modulators, as I mentioned, for estrogen. And then we have other type of drugs that can be used. So we can have the GnRH analog that I mentioned earlier. Some drugs are different, but the mechanism is exactly the same. We can also have CYP17 inhibitors, and there's only one drug, is abiraterone. CYP17 is an enzyme, an enzyme complex that is involved in the formation of testosterone. Okay, so this you don't have the detail here, but it's not a big deal. You have many steps that lead to the formation of testosterone, and CYP17 contain two enzymes that are involved in the formation of testosterone. So by inhibiting this enzyme, you will inhibit the formation of testosterone. Okay, so we decrease the synthesis of the hormone. And here we have also a different class that we didn't have for women, for estrogen, the GnRH antagonist. So the target is the same than the GnRH analog, but here it's more logical. This is an antagonist that will block the effect of GnRH. So then the consequence is that the endogenous GnRH cannot stimulate its receptor, and then you will stop to have synthesis of different of the cascade enzyme. Okay, so you don't have the problem. I mean, you don't have the desensibilization, and then the mechanism of action is more easy. And we put an antagonist on the receptor, so the endogenous GnRH cannot stimulate. Okay. So I'm not going to tell you more about this, except that prostate cancer, as I mentioned, you start the treatment with this type of combination drug. When the tumor progress, you can change of drug class to get more effective drug. And then if it's not working anymore, if the prostate has become hormone independent, then you will have to switch on chemotherapy. So now we move to targeted therapies, the third class of drug. So there are different types of targeted therapy, but as the name mentioned, we are going to target a specific molecule. So this specific molecule are specifically expressed in tumor cells. That this is what we want, or its microenvironment. However, you will see that some of the targets that we use in targeted therapy are also expressed in normal cells, and then you can have side effects because of this expression. And so most of the time, the targets are oncogene products that had a role in the neoplastic transformation of the cancer cell. And the main difference with the cytotoxic class is that they will require continuous exposure to inhibit their target. So we don't have the problem of the bone marrow and the progenitor and toxicity. So in this case, we will give the treatment in a continuous way. Okay. For some drug, you may have some 1 week window without drug because of the toxicity, but most of the time it's not hematological toxicity. But for you, I suggest you to remember that the exposition must be, the exposure must be continuous. So we have different categories of targeted therapy. So we have some drugs that target the causal molecular abnormality. So what I mentioned earlier, like the oncogene that was responsible for the transformation into cancer cells. So the most famous example is BCR-ABL in the chronic myeloid leukemia, CML. This is really the oncogenic step that makes the cells become cancer cells. So this is what we inhibit. And you have other examples like mutated c-KIT, which is a receptor in some gastrointestinal stromal tumor, like mutated BRAF and melanoma. We know that the mutation is the cause of the tumor. So this is what we call the concept of driver mutation. Does everybody know this name or not? Okay, driver, you know what is a driver? This is the one that drives the car. So here we are calling driver mutation because it drives the tumor, okay? This is really what makes the tumor proliferate. And therefore, this is interesting because if you kill the driver, then you can expect to have an effect that is very impressive. Among the targeted therapy, you can also have some drugs that target molecular abnormalities that contribute to the tumor progression, but are not the driver mutation. Okay, so we don't have driver mutation all the time, but you can still have some receptor or proteins that we know to contribute to the cancer. For instance, this is the case of HER2 receptor in breast cancer. So this is not really an oncogene. However, we know that it can be overexpressed in tumor, and its overexpression is in line with a worse prognosis, a worse response to drug. So this is something that we want to target. And in this category, you can find also the tumor neoangiogenesis. So the angiogenesis is the fact to have a blood vessel going to the tumor. And so we are not going to target tumor in this case, but we are going to target the vessels and the endothelial cells that are responsible for synthesizing these vessels. And we know that in this case, the angiogenesis contribute to the growing of the tumor. And the last example is to have a targeted therapy against a molecular target that is not involved at all in the cancer, but just allow to target the cells that we want to kill. So this is the case of CD20 antigen in lymphoma, and with the rituximab, this is an antibody directed against CD21, and it's just a way to recognize the cell we want to kill. But CD20, sorry, is not the cause of the cancer. So among the targets that we that are the most used target in this targeted therapy, this is the class of tyrosine kinase enzyme. Tyrosine kinase can be receptor, like tyrosine kinase receptor, but you can also have a cytosolic tyrosine kinase enzyme, okay? So what is it? A receptor that is a receptor kinase, a tyrosine kinase receptor, sorry. This is a receptor with, I guess all of you know that, with an extracellular domain that is involved in the recognition of the ligand, okay? And there is in blue an intracellular domain which has a kinase activity, and tyrosine kinase activity means it will phosphorylate the tyrosine residue of other proteins. So here you have a representation of different tyrosine kinase receptor, and you can recognize, for example, the insulin receptor, which is not involved in oncology, except that I guess there are a few EGF receptor inhibitors that are in development. But for example, EGFR, for epidermal growth factor receptor, is involved in some cancer, and it's, for example, a target of targeted therapy. In the second slide, you can see intracellular protein kinase, tyrosine kinase. So these are proteins that are in the cytoplasm and act as a kinase, as a tyrosine kinase. So they all have a kinase domain in their structure. And you can recognize, for example, ABL, which is involved in the BCR-ABL oncogene in CML, that has also this kinase domain. So just for those of you that don't have a biological background, those tyrosine kinase receptors, they work in this way. When they bind to a ligand, they will form a dimer of receptors. So it can be a homodimer. It means that the receptor with who is coupled is the same, or heterodimer is a different receptor than this one. And then the kinase domain that are here are going to phosphorylate. You can see here the Y letter represent the tyrosine residue. Will phosphorylate the tyrosine here. And then the fact to have a phosphorylated tyrosine here will interact with some adapters molecule that will activate different pathway, and all this pathway that you may know, MAP kinase, PI3K-AKT, they are involved in proliferation, cell survival, angiogenesis, and metastasis. And they all work by, at the end, finishing into the nucleus, and they will increase or decrease gene expression of specific genes that are involved in this mechanism. So this is the general mechanism of action. And if I come back to my to the inhibitors that we can use and to this concept of mutation driver, well, we know today that, for instance, EGFR receptor can have driver mutation in the kinase domain of the receptor, and then we have developed inhibitors of this activity.
you also have here BRAF, I mentioned earlier. BRAF can be mutated, and this is a driver mutation. And so it exists some inhibitors of BRAF to inhibit this pathway. Okay. So we have different strategies to inhibit the tyrosine kinase activity. And for the receptor, you have 2 or 3 main strategies. The first one is to use a monoclonal antibody that will act on the extracellular domain. So for everybody, antibodies are very big molecules that cannot enter inside the cell. Okay? So the target of an antibody is necessarily an extracellular domain or an extracellular. So for example, here we can use antibody directed against the ligand binding site of the receptor. Or you can also use antibodies that are directed against a circulating protein. For instance, this is the case of bevacizumab that we mentioned earlier. The bevacizumab will recognize the VEGF, so the vascular endothelial growth factor that is circulating in the blood. It will recognize it in the serum or in the blood, and then it will form a complex so that the VEGF cannot go on the cells, on the endothelial cells, to activate its receptor. Okay? So this is a particularity because most of the antibodies are directed against a receptor, but bevacizumab has a different mechanism of action. And the second way is to use small molecule that will enter inside the cell to inhibit directly the tyrosine kinase domain. Okay? So for that, you need to have a lipophilic drug that can enter easily inside the cell, and then you can inhibit the tyrosine kinase domain of the receptor, or if you have a protein that is in the cytoplasm, directly act on the kinase. So these molecules are easily recognizable. These are small molecules, and most of them have a name finishing by inhib. Okay, so inhib you can be sure that inhib is a small molecule lipophilic that enters the cell and that will act directly on the kinase domain. They have an intracellular action. The mechanism of action indeed is a competition with ATP. So I don't know if you guys know that, but on the tyrosine kinase domain, you have a pocket that allows the ATP to come. And this ATP is necessary to get the phosphate that the kinase needs to phosphorylate its substrate. Okay? To be able to phosphorylate, you need to have a phosphate. Then the ATP is here to give the phosphate. So the inhibitor, the TKI, the tyrosine kinase inhibitor, they take the place of ATP in the pocket, and then the kinase doesn't have any phosphate, so it cannot phosphorylate any protein. Okay, so this is a competition with the ATP to this pocket. So a few information about these 2 types of molecules. They are very different, you have understand, antibodies against lipophilic TKI. And so they have very different pharmacokinetic properties. And there are a few information that you need to know. Maybe it's obvious for you, but and I will be happy if it's the case. So for monoclonal antibodies, you cannot give them by oral route, okay? Because these are peptides, and if you take them by oral route, peros, it will be completely degraded in the stomach, and then no action, okay? So antibody needs to be given by IV route, and sometimes you can use subcutaneous route, but it's not the most frequent way to give this. The monoclonal antibodies, when like most of them, if they have a normal structure of antibody, they have a long half-life, about 2 weeks, 3 weeks, okay? If you have to remember a time, you can remember that the half-life of an antibody, even the one that we produce, are about 21 days, okay? So, if you give an antibody to a patient with such a long half-life, you don't need to make an injection every day, even though I told you that we need to have a stable exposure to the drug. Okay? If the half-life is long, then the patient will be exposed to the drug for 1-2 weeks, and then the next injection can be in 2 weeks. And even though you have 2 weeks without injection, the patient will be impregnated with the drug. Is it clear for everybody? So it's the same type of regimen than chemotherapy with cycle, but the goal is very different. Okay. For chemotherapy, we do cycle because we don't want to give, we want the bone marrow to recover. Here, we just do cycle because the half-life is very long and we don't need to give the drug every day. Okay, but the exposure is continuous. And those drugs, they don't have hepatic or renal expression or metabolism. So it's quite easy because you don't have the risk of drug interaction, or even though the patient doesn't have a good renal function or hepatic function, you don't have to make complicated dose adjustments. It's not a drug that is metabolized in the same way that a typical drug with hepatic metabolism, for example. Okay, and for the inhib, then it's different. It's small molecule that can be given by oral route, so it's easier. I mean, I don't know if it's easier, but the patient doesn't need to come at the hospital. It can take home. It's a daily administration most of the time, but those drugs are metabolized by the liver, by the CYP3A4 enzyme, and there's a risk of drug-drug interaction. So the handling is quite different with each drug. Yeah, I just put this slide to maybe you don't know that, and so about the MABS pharmacokinetics, I told you that the hepatic and the renal function is not involved, and indeed we know that the antibody are eliminated by 2 types of mechanism: a saturable phenomenon, which is in line with the binding at the tumor. Indeed, when the antibody recognizes a receptor on the tumor cells or on a normal cell, it will be internalized inside the cell. And so in this way, it will be degraded by the lysosomal enzyme within the cell. So this is a tumor-dependent elimination. And then you have what we call a non-saturable phenomena with the endothelial cell that also participate to a catabolism of antibodies. And I wanted to mention something, and I don't know if you know about that. Those antibodies, and this is the case for drugs, but this is also the case for our antibody. They have what we call Fc fragment here, and this Fc fragment can be recognized by a receptor that we call FcRn that will protect the antibody from degradation. And so this is because of this protection that the half-life is so long for antibodies. And so in this slide, you have this mechanism of recycling of antibody. So this is true for endogenous antibodies, but also for drug antibodies. So you can see that antibody will be internalized by endocytosis. And when they are in the lysosome, because of the pH that is more acid, the FcRn that is expressed in the lysosome will recognize the Fc fragment of receptor. And then instead of degrading the receptor, the fact to be recognized by this FcRn receptor will allow to recycle the antibody, and then the antibody will be released again to go in the circulation. Okay, so this FcRn receptor is a way to prolong and to make longer the half-life of the antibody. So I just mentioned a few examples of half-life for drugs. So about this targeted therapy, there is now a very big list of them, and I will not go through all of them. And you just need to remember the concept and the difference between the MABs and the IMIBs. As I mentioned earlier, the first one was imatinib in 2001. And we will just say a word about this drug. And I'm not going to detail all this drug. Even for us, it's quite complicated to follow because the development is very active, and every year you have new drug coming out of the market, and it's hard to follow. But I will just say a word of the example of BCR-ABL, which is a typical example of a master oncogene that has led to the development of imatinib. So BCR-ABL is actually a fusion protein that is caused by a specific translocation in a disease, the chronic myeloid leukemia. So you have chromosome 9 here that has the ABL gene and the chromosome 22, the BCR gene. And in this pathology, there is a translocation that makes a part of chromosome 2 going in chromosome 9. And then you have the formation of what we call a Philadelphia chromosome. This is a fusion of BCR and ABL. And this fusion cause a kinase with a constitutive activity. It means that it doesn't need any ligand to be activated. It is all the time activated. So it phosphorylates all the time the substrate. And the effect of this kinase is to provoke proliferation. So the cells start to proliferate without any control. And this is what we call chronic myeloid leukemia. So in 2000, some companies started to develop inhibitor of BCR-ABL. L'enjeu en fait pour c'était it was to have something that was specific of the kinase of BCR-ABL. Because as you have seen, we have many kinases in our body, so we don't want to inhibit all the kinases. And all the kinases have some specific sequence that may be the same in all the kinases. So the difficulty here was really to have a specificity, a selectivity for the BCR-ABL kinase. How to recognize the selectivity of a drug? Well, you can look at the IC50 of the drug against different types of receptors. Okay, so this is something that you all need to how to know that, and I don't know if you are familiar with that, but the smaller is the IC50, the more the drug is has an affinity for the specific for the protein. Okay, so here, for example, 0.21 for VABL, 0.25 for BCR-ABL means that the activity against the kinase will be the same for these two tyrosine kinase, okay? And the fact to have a very high level of IC50 here means that the drug will not be active, will not recognize the EGFR kinase, the HER2 kinase, So this is pretty good because it means that we will not have cross selectivity against the kinase. Okay. So it was pretty nice to see that. However, you can see that the imatinib also have an activity against another receptor, the PDGF receptor, which is also a tyrosine kinase. And so some effects of imatinib might be linked with the inhibition of this kinase. Okay. So this figure just show you what I mentioned earlier, the fact that they are, so the STI 571 is the imatinib. And as I mentioned earlier, this imatinib acts by competition with ATP in the specific pocket of ATP. And so this inhibits the effect. And what you can see here are the first results that were obtained with the imatinib. So here, imatinib is CGP 57148. And the red and the green cell lines are the cell lines that express BCR-ABL. Okay. The other cell lines, the MO5, MO7, does not have BCR-ABL. So we can see that imatinib has a specific activity on the cells that express BCR-ABL. And it was confirmed in mice. And therefore, we had quite a record development time for this drug. And this is like an historical example. Most of the time, you can see that a normal drug development may take 8 years from the discovery to the authorization for patients. And in this case, the effect was so interesting and such a revolution that the development time was reduced to three years. Okay. And still today, so imatinib has been, there is also new drugs working on BCR-ABL, but it's still like a major drug used in this CML pathology. So the problem is like to choose the target because you will see that in the different workshops that you will have, but there are many target kinase, and now we also work in other type of target that are not kinase that can be involved in the proliferation. And so I have tried, but it's not exhaustive. I have tried in this slide to make kind of basket where you can put together the targeted therapy in line with the type of tumors that are treated by this therapy. But you can see that in hematological tumors, so of course we have BCR-ABL, I just mentioned them, but we also have other inhibitors of specific protein, cellular protein that are involved in hematological tumor. We also have EGFR inhibitors. So we have two types of inhibitors. We have MABs and we have INHibs. And surprisingly, they are not necessarily authorized in the same pathology. So the EGFR inhibitor is used in digestive and head and neck cancer, whereas the small molecule EGF inhibitor are used in lung cancer. I mentioned angiogenesis inhibitors, so they have multiple indications, but they are particularly active in kidney cancer. I don't know if some of you, maybe the most, those who are in the CFC program, do you know why kidney cancer are concerned by angiogenesis inhibitor? Or maybe, do you know why angiogenesis inhibitors are so effective in kidney cancer? Because we can think that angiogenesis is not organ related, like all the tumors need to have blood vessel, and we can think that angiogenesis can be effective in every tumor. This is quite true because, as I mentioned, other tumors are concerned, but in kidney cancer, we have a specific a specific syndrome, which is called von Hippel-Lindau mutation, deletion. Von Hippel-Lindau, it's VHL. And this defect in this specific cancer cause an overexpression of a protein that is called HIF, HIF, which is hypoxia-inducible factor. Maybe you have already heard about it. HIF, and this HIF factor activates the angiogenesis. Okay, so these renal cancer are actually cancer for which angiogenesis is very important and very activated. And this is one of the reasons why the angiogenesis inhibitors are so effective in renal cancer. And then you will have, so BRAF inhibitor, as I mentioned, most involved in melanoma. And for breast cancer, you have also different type of targets. So yeah, this is, you will see some of them during the workshop that you are going to have in the class. Maybe I will accelerate a little bit. I just wanted to mention something about the antibody mechanism of action. So we said earlier that they can inhibit the binding of the ligand, and this is one of the main actions. For instance, here you have trastuzumab that is linked to its receptor HER2, but actually this is not the single way they work. For example, for trastuzumab, we have identified many mechanisms of action. The first one is quite complicated, but the HER2 receptor, for instance, we don't know who is the ligand of HER2. HER2 is a particular receptor for which we have not identified the agonist, the endogenous agonist, the endogenous ligand. But we know that it is involved in many mechanisms, and especially in cancer and in breast cancer. And so there are hypotheses, and it has been verified, to explain how HER2 can activate itself without a ligand. One explanation is that he is able to cleavage, to break his extracellular domain here. And when he does that, it's going to activate the pathway that is beyond. Okay? So when the trastuzumab, the drug bind to the HER2, it's going to inhibit this cleavage, and then it's going to inhibit the activation of the receptor. So this is one of the mechanisms of action for trastuzumab. Another mechanism of action, when trastuzumab binds to the HER2 extracellular domain, it will inhibit the dimerization of HER2 with another HER receptor. I mentioned earlier that this receptor, when they are activated, they are going to make dimers and activate the pathway. Well, in this case, HER2 cannot make a dimer with another receptor, and then you will interrupt the signal. And another mechanism that is very important, and this is why I wanted to mention that, is what we call ADCC, antibody-dependent cell cytotoxicity. So I guess you have seen that in immunology courses. The ADCC is the fact that whenever you have the Fc fragment on the membrane of a cell, be it a drug or our antibody, it will be recognized by your immune effector cells, such as NK or macrophage, and it will kill the cell, and it will lead to tumor cell lysis. Okay, so here the fact to have an antibody with the Fc fragment, it will be recognized by the cell, and the tumor cell will be killed, which is actually pretty nice because this is what we want. So this is an effect that contributes to the effect of trastuzumab. And the last mechanism is that when the antibody is linked to the receptor, it will be internalized. So we have a decrease of HER2 expression on the cells. So I already mentioned the type of targeted therapy which are the more common, the INHIB and the MAP. And now we have a new class of drug, and I don't know if you already have heard about that, that we call antibody conjugated or coupled to a cytotoxic agent. So the name is ADC. So these drugs are very interesting and very innovative. It consists of an antibody. So here we have trastuzumab, the same that we saw before, that is specific to HER2. But on this trastuzumab antibody, we have linked some cytotoxic drug. And here the drug is a topoisomerase 1 inhibitor, DXD. And in purple, you have here the linker. So it's not active, it's just to, it's allowed to stick the cytotoxic drug to the antibody, okay? And so this ADC can have a high number of cytotoxic molecules. Here you have eight cytotoxic molecules in one antibody. So how does, so this is, these are pretty recent drug, but we have approximately 10 ADC that are approved in Europe. And they all have this type of name, like trastuzumab deruxtecan, enfortumab vedotin. So it's like the first one is the name of the antibody, and the second name is the name of the cytotoxic drug. These cytotoxic drugs are very, very active, and most of the time they cannot be used by itself. They are so toxic that they are not used alone in patients. What allows us to use them in ADC is the fact that they are linked with an antibody, so they will be released specifically in the tumor cells. Okay? So how does it work? This is the mechanism of action. So this is an antibody. So the antibody will recognize a specific receptor. So for instance, for trastuzumab deruxtecan, the trastuzumab will recognize the HER2 receptor. Okay. So this is a cancer cell expressing HER2. And then the receptor will be internalized. And once in the lysosome, the linker will be cut and the cytotoxic drug will be released. So DXD, in the case of trastuzumab deruxtecan, this is a topoisomerase 1 inhibitor. So it's like irinotecan, for example. And then it's going to act on the DNA and inhibit the topoisomerase and have a cytotoxic effect. So these drugs are between targeted therapy because they use an antibody to target the cell, but this is also cytotoxic because they use cytotoxic drugs, okay? And so the cell will be killed by the effect of the cytotoxic. There is also what we call a bystander effect. Bystander effect means that the cytotoxic will be released outside the first cell and can go and act on other cells independently of the HER2 expression. So this is something that can be good because let's say that if the cell that is next to the first one does not express HER2, it can still be treated by the cytotoxics because of the bystander effect. Okay. Another new class of drug that I wanted to mention before the end of my presentation is what we call bispecific antibodies. So BS-ABs, bispecific antibodies. So the definition is that this is antibodies that are able to bind two sites. Okay. So the the first category of bispecific antibodies are a type of antibodies that are able to bind two receptors. So this is what we call dual receptor inhibition, and this is better than blocking only one pathway. And sometimes it's also better than using two different antibodies. So this is the case of this drug, for example, amivantamab. So this is an antibody that will block EGFR and c-MET. And this is interesting in certain type of lung cancer that has EGFR mutation, because c-MET is also a receptor that is involved in the oncogenesis and participate to the proliferation of tumor cells. So in this case, you will block two pathways instead of one. And this is why this drug is interesting. So these are a pretty new drug. And so the mechanism of action is to decrease proliferation because the inhibition of the receptor, but also it will trigger the ADCC thanks to the FC fragment field. Okay, so it will allow the immune cells to come and kill the tumor cell. And in this figure, I show you just the number of drugs and the number of bispecific antibodies that are in clinical development. So TA means tumor antibody, tumor antigen. So this means tumor antigen that are specific, and this is different types of antibody that we can use. But you can see that we can have also bispecific antibody targeting soluble factors such as VEGF or angiopoietin 2, etc. So this is a very active research, and I'm pretty sure that in 5 years you will have a lot of new drugs that are bispecific. Bon, je suis très en retard. Je passe les mécanismes de. So I'm quite late, so I'm going fast on the mechanism of resistance because you can understand it just by reading the slide. There is no difficulty. So this is an important chapter, and I'm sorry I cannot go through, but I really recommend you to read the slides and the mechanism of action. And I just wanted to mention the last mechanism of action, that is immunotherapy. Maybe most of you know that because you had probably one class about it or not. So what we call immune therapy are mostly now what we call checkpoint inhibitors. And checkpoint inhibitors are a specific protein that allow the cancer cell to avoid the degradation by immune cells or the recognition by immune cells. What you should know is that when we have a cancer cell, you have a lot of mutation in the DNA of the cancer cell, and it will express tumor protein that will be released when the cell will die. And this protein, we call them tumor antigens. These tumor antigens can be recognized by an antibody presenting cell. Here, they will be recognized and they will be processed, and they will activate T cells. Okay, so they will T cell will recognize the antibody. They will be activated, and they will go back to the tumor, and they will be able to kill the tumor by recognition of the neoantigens. Okay, so this is normally what happens and what should happen. And our immune system is supposed to kill the tumor cells because of this mechanism. However, this is limited by the checkpoint inhibitor that are breaks that allow the cancer cell to avoid this mechanism. And so the immune therapy mechanism is to boost the immune response of the body by lifting the brake. And more specifically, so you will see that in a specific workshop, so I'm not going to detail too much, but what are these brakes? For instance, here, when you have a T cell here and a tumor cell here, you can see that the T cell expresses some protein, such as PD-1 here, that can be recognized by the tumor cell that express PD-L1. And the fact to interact together is a negative signal to the T cell saying, don't kill me. Okay? So when this interaction happens, the T cell has a message saying, I don't kill this cell. Okay? So this is not good because it won't kill the tumor cell. So the immune checkpoint inhibitors are antibodies. So you can see them like in my slide, in green, purple, or blue here, antibodies that inhibit this interaction between checkpoints. And then if there is no interaction, then the T cell will actually kill the tumor cells. Okay? So this is the main immunotherapy mechanism, and you will see it in detail in the different, in the workshop, and for some of you, you already have that. This is the first immunotherapy drug. They have 10 years now, and there's a lot of cancer that can be treated with this drug. Okay, so don't need you to remember, but they are very popular, and they have a lot of indication. And just to finish now, what we have is also bispecific antibodies, as I mentioned earlier, but they can be able to bind 2 checkpoints. So this is the case of this drug, for example, that will recognize PD-1 and CTLA-4. So this is a dual checkpoint inhibitor. But this is less, for the moment, there is no that much example. What is very popular now is what we call T-cell engager. So these are bispecific that recognize CD3. CD3 is a specific of lymphocyte T. And on the other side of the antibody, you have a protein that is expressed in the tumor cell. So what allows this type of antibody is to put together a T lymphocyte and the tumor cell and activate them so that the T lymphocyte will kill the tumor cell. So I have a slide showing that. And you should look on the right of the side, what we call bispecific T-cell engager. These are small molecules. This one is a small molecule recruiting CD3 here, so a T cell, and CD19, which is a specific of some malignancy, hematological malignancy. And then the fact to link those 2 cells and activate the receptor will make the T cell kill the CD19 positive cell. And you also have this type of drug. This is the main mechanism, but with a FC fragment here, contrary to this one, or doesn't have a FC fragment. So if you remember well what I said, the fact to have a FC fragment, it can last the half-life. So this is a pretty nice effect. However, it is also involved in ADCC. And so the problem here is that if you have too much FC fragment linked with some cancer cell, you can produce too much ADCC and you can have a lot of side effects. So some of this type of drug have been withdrawn because they have too much side effect because of the FC fragment. And that's what I mentioned here. And so we have a few examples. You see, like blinatumomab is the most used drug. It doesn't have a FC fragment. The problem is the half-life is very short because of the absence of FC fragment. So it will require a continuous infusion, which is not easy to handle. And this is my last slide. This is the scheme I showed before. Okay, thank you very much for your attention.